Hello, this is Dr. Brian Lippincott, and I am a clinical psychologist and a professor of psychology at the John F. Kennedy School of Psychology at National University. And I'm happy to be here. I'm going to give you a little lecture now on on neuroscience and trauma, the current neuroscience research in the field in trauma, and how that relates to Jungian psychology. I'm the author of the book Analytical Psychology and Family Systems, Neo-Jungian Practice to Help Families Find Flow. So I'm a flow neuroscience coach and amongst other things. Okay, let me share my screen. Okay, so here we go. Let me kind of get some of this stuff out the way. Okay, so trauma, neuroscience, and the path towards growth. And what we're talking about there is post-traumatic growth. And that's a wonderful symbol there of a tree, like a tree of life with all the different branches, or a multi-generational family tree, but with some of that Kazuki, where when it's broken, sometimes there's gold in them there hills. There's gold that grows out of the situation of our trauma, which we'll talk about for therapists in this case. This is a class in training therapists. I'm also a super clinical supervisor at De Anza College Mental Health Services, and I'm also a supervisor at the Center for Embodiment Medicine in Santa Cruz and in San Rafael. Okay, so integrating clinical assessment with positive psychology, flow science, and classical assessment techniques in trauma. This presentation bridges the gap between the diagnostic and the therapeutic. We will trace the arc from the neural imprint, that biological reality of trauma that really impacts us in the fight and flight and the freeze, the flock, uh, all those F's that bring us together in a frustrating situation with trauma. Through the tools we use to map it, we will conclude with the framework to facilitate post traumatic growth. That's so many times I have had students, clinical students that are becoming therapists, and they come in and they say, "Oh, I was traumatized. I need to work on myself. I'm a victim of trauma." And then they move along and they say, halfway through the program, they say, "Brian, I'm a survivor of trauma. And then they say, so they're no longer a victim, they're a survivor. Then finally, when they graduate, they say, Brian, um, I don't know how to say this. It's kind of interesting, but I'm actually glad those bad things I told you about before happened to me, those terrible things, because now it's given me insight and a caring and an empathic attunement where I feel like I can help other people with those same problems and even improve my effectiveness as a therapist." And this is when they're in the practicum class that they do that. So, Act One, the neural imprint. Act Two, mapping the terrain. How are we going to use assessment tools? And then that's what we want is the path towards wholeness. Okay. The neurobiology of trauma, the triple network model. So we first of all we have the default mode network. That's in the back of the brain. Okay, that's where you're kind of ruminating over things. That's like when I'm swimming and we're actually swimming and I'm in a flow state, but the back of my mind is thinking about this lecture and how I want to organize it, what kind of slides I want to make, all that kind of thing. The default mode network is self-referential thought through rumination. That's where I'm working through those things in the back of my mind. The salience network, the switch for threat detection. So the salience network is the situation where you'd rather see, and walking in the woods, you'd rather see uh, 1,000 snakes, but it's really a stick. For that one time, it might be a snake. That's what's important to your survival. This is that survival network that gets switched on in the polyvagal arousal aspect when trauma happens, and then because you're constantly scanning vigilantly for, like, if you were abused by when they're in a gas station, there's a smell where there's a when you put water on concrete. And I had a client once that was really badly abused in a gas station on a very hot day, and when the steam rises off of the concrete, it has a certain smell, and she would be walking the dog and smell that smell, and it would trigger all these feelings, and eventually we had to work through that. But that's the salience network, that smell was salient to her after that terrible incident. Then we have the front part of the brain, the central executive network. This is cognitive regulation, balancing your checkbook, executive control, deciding what to spend money on, or what to invest in, all those kind of things that happen. That's the central executive network that makes decisions. Now, when you get into a flow state, that gets dysregulated. That allows you to get back into these other states. So that's why flow and the flow state that athletes use, the zone. Mihaly Csikszentmihalyi is the author of all the work on that. Stephen Kotler is the new person that's doing research into that. Right now, he's doing research on Jung's concept of synchronicity and being in flow. That maybe when you're in flow, you seem to have more synchronistic events. So, trauma disrupts the synchronization between these networks. In survivors, the salience network often shows increased activity, vigilance, functionally impairing the central executive network. So, trauma can turn this off too, and flow can turn it off. Okay, so maybe flow has some adaptive states to aspects to it that has helped us adapt and survive in the rough times we had coming up in the world. Recently, resting state EEG, okay, the EEG when you're resting, imaging revealed that the theta band connectivity within the salience network mediates the relationship between childhood trauma, emotional abuse, physical neglect, your ACEs score, as we talk about that, and adult anxiety. So the salience network is mediated by trauma and kind of caused to be much more like a cat on a hot tin roof, much more stimulated and easily aroused. Hemispheric specialization. Okay, this is my old, my dissertation advisor, Ernest Rossi, was a Jungian analyst. He was the editor of Psychological Perspectives, which is the Jung Institute of Los Angeles period a magazine or their journal, academic journal for all these years. And he was also editor of the collected works of Milton H. Erickson, the famous hypnotherapist that was part of solution focused and strategic family therapy, and worked with Gregory Bateson at the Mental Research Institute. Well, he talked about the Jungian connection with the left and right brains, which we all know about left: language, analytical reasoning, sequential processing, emotional processing, holistic thought, spatial awareness. So you're thinking about some things that are really, really tied in with trauma there. Introverts are right hemisphere dominant, usually. Okay, now there's dominance and there's activity. Okay, those are two different things. Like I'm left brain dominant, but biological rhythms every 90 minutes, about every 90 to 120 minutes, we shift from activity being more higher in our left brain to activity being in our right brain, to left brain to right brain. But we can override that. That's part of the problem with our school kids in school. It's all, we've gotten rid of PE, right brain. We've gotten rid of art, right brain. We've getting rid of drama, right brain. We've getting rid of dance, right brain. We've getting rid of all the right brain activity, and then we have left brain, left brain, left brain, left brain, left brain all the time. No wonder when the kids get home and they want to shift to the right brain, and all they want to do is play video games or go on a video and veg out or whatever. We need to think of better ways to get that, but we really want to shift back and forth as far as activity, but we have one side that's dominant. The clinical implications are right hemisphere dominant survivor, okay, might respond better to visual spatial therapies like art there, which we get more into that in some of my other videos. I've gotten into techniques you use when you have a person who can't use visual cues that they and also people that have alexithymia that you might have to use visual spatial cues therapies like somatic therapy and dance therapy, authentic movement therapy because of their cerebral hemispheric dominance and just who they are as a person, mapping the terrain. Just a little bit about trauma and the MMPI 3, the trauma profile, key indicators, anxiety related experiences. That captures the intrusive thoughts that uninvitedly invade the mind. That's similar to almost what we call unattached burdens in IFS, internal family systems. That's a whole other thing we'll talk about maybe if we have time. You can ask questions about IFS in this, but IFS is really good for anxiety related experiences, but unattached burdens are like the intergenerational trauma that people have, that kind of thing that goes back, even though great grandchildren of people that went through the Holocaust still have markers of um, uh, um, of trauma in their testing. The emotional internalizing dysfunction indicates severe internal struggles with emotional realism. Demoralization, that's a really one that the person has been traumatized. It's like learned helplessness. The way they first discovered learned helplessness is they were trying to study rats and how quickly and what were the factors that would have them learn to run through a maze quicker. And they found out that if they electrified the maze, they would run very quickly and they would quickly learn their way out. But if they electrified it and then they would go a little way and they would start to go out, but they would unelectrify it and they would start to go the other way, they would electrify it, just random. Finally, the mice just got to a point where they just gave up and laid down because it was so, in other words, pain that's predictable is easier to deal with than intermittent pain and no pain that's not predictable. That, in other words, the unpredictability of it causes demoralization on the scale in the MMPI. Dysfunctional negative emotion, the shadows of distress in dysfunctional negative emotion manifest as silent waves of worry and the inability to relax. And sometimes there are medications that we give for psychosis and other things that cause that inability to relax. So let's talk of a case study on the MMPI of Tom, a Vietnam vet or Iraq, sorry. I started off cutting my teeth on Vietnam vets, but Iraq war veteran, witnessed friend suicide, feels responsible. And in the MMPI, he has a floating profile, high scores on 6. It's kind of like almost a sawtooth, kind of like 2, 7, 8, the keen PTSD scale. He has heavy guilt, low morale, that he's demoralized. That's the depression scale, scale 2. Scale 7, he's ruminative anxiety. He has intrusive thoughts. He can't get this events off of his mind. It just goes over and over and over. It probably leads to nightmares and other phenomena like that. He has social alienation, not psychosis, even though unfortunately we call that scale 8 schizophrenia. It's social alienation. He's not alienated, he's separated from his family. He can't connect with people. He doesn't have that in Jungian psychology, that communitas, that ability to bond and let yourself go and be with other people, kind of what we call participation mystique or participation, where you really can let go into a group, a team, a spirit. Tom's heart carries the heavy weight of guilt, haunted by the feelings he failed to prevent a tragedy. Now let's look at the WIS 5 with children. Okay, the full scale IQ. We have the verbal comprehension index, the perceptual reasoning. The verbal comprehension is your answers to verbal questions like who is the president, where, like all those kind of things. Perceptual reasoning index, as you know, was your ability to figure out things perceptually and coding and that kind of thing. Working memory is your ability to like remember what you're talking about and follow through. Working memory and processing speed. Now, these are the key thing to this whole with a kid and trauma is if somebody is traumatized, these ones in red are the ones that are going to have a problem. And I remember the first time I was just learning how to give the whisk way back when it was the whisk, just by itself, not three. But it was the same basic idea of a test. And this girl had just lost her dad 2 weeks before, and I had to do a psychological a whisk test with her, and I could tell on the time test. I mean, she like when is winter? She would like roll her eyes and say, "Why the hell is this fool asking me these dumb questions? My dad just died." But then she would finally say, "Oh, that's between spring and summer." I mean, between fall and spring, and answer it. But on the time things, if you don't get right, if you're really smart, you don't get your full points if you don't get right on it. Okay. So the trauma pattern, persistent stress disrupts the prefrontal cortex and the hypothalamus, hippocampus. Okay. So working memory, difficult holding and manipulating information. Your working memory is in your holding it in your working memory, not your long-term memory, like I have problems with. It's your working memory. The PSI, that's the processing speed, how quickly you process things. Slowed performance on time tasks due to hypervigilance. Insight, what I want the take-home point of this is a traumatized child pauses during time tasks because they perceive the demand as a threat. Why is this fool asking me to do this? I put the word fool in, but I mean, if you haven't got a lot of trust in people, what are you going to think? Now, the case of Leo, cute. The baggage carried into the classroom is he has a split profile, a significant discrepancy. He's 10 with a history of domestic violence. Verbal comprehension is intact, 105, a little bit, he's good. He's in the middle. It's like all of us. Okay. Working memory, low average. Processing speed, even a little bit lower. Okay. Hyper vigilant. He's so hyper vigilant on all these millions of things, he can't focus on the task. The part of his brain that turns off the other part of the brain in the prefrontal cortex, there's a part that shoots down other things so you can focus on one thing. He can't do that. That's the impact of trauma. That's the hypervigilance. So Leo has a silent struggle. Leo appears nervous, scanning the room for exits. Eyes are shifty. His low processing speed isn't a lack of skill, it's the result of anxiety hijacking his neural resources. This discrepancy between potential IQ and performance is a clinical red flag for trauma, amongst other things, but trauma is a very big part of it. Now, here we go into post traumatic growth. But this is what we hope therapists that have had trauma or your own self care ties in the paradigm shift from helplessness to optimism. So we start here in the deficit model. That's where we all start. Trauma, inescapable shock growing up. Learned helplessness, as I talked about, where we just give up. Deficit, we have symptoms that are trying to balance us out by giving us anxiety or depression or things to try to fix us to get us back on track, but it's a symptom. Causes pessimism and disruption. Then that can put us in, we could start drinking and get more shock. We can stay in this, or we go to therapy and we get this clinical pivot. That's what we're trying to do. We have a strength-based model here in therapy. These are vicious cycles, deficit cycles, vicious symptomatic cycles. We want to get wellness, health-based. So the greatest gift you can give is just focus on sleeping. Are you eating? Are you hydrating? Are you doing your breathing exercises and getting yourself oxygenated? A little bit of exercise, all that. So strength-based model, we focus on strengths. We experience adversity. We start to overcome the adversity and we get learned optimism, which is the opposite of learned helplessness. We learn, hey, I can do these things. And it's like, because when we're children and we're abused, for instance, then all of a sudden I'm a 40-year-old man. I still am operating under that same internal working model. They call it in emotionally focused therapy and in attachment theory. Your internal working model is that the world is dangerous. People are out to get you. They can't be trusted. So we have to change that internal working model through attachment and connection and communitas with others and family flow and getting in experiences where we experience that flow. Then we start to learn optimism. We get agency and resilience. And resilience is a whole other thing we could go into just in that. But then that focused on more strengths, and we get into this vicious wellness cycle, moving from what's wrong with you for what's strong in you. The framework for doing this in flow science for flourishing. This is for flourishing. Okay. PERMA, PERMA, positive emotion, engagement, relationships, meaning, accomplishment. So, positive emotion, finding flow to counteract intrusive memory. So, you're doing swim. When I do my swimming, I feel so much better. Engagement, utilizing your strengths to gather and tackle challenges. Relationships, that's your communitas. Moving from trauma coerced attachment to a safe co-regulation, learning how to co-regulate with each other and having a group, because no one person, partner, lover, whatever, can be there 100%. Therapist, you got to have a group of people, a network, to have communitas in those relationships. Meaning, finding purpose beyond the trauma narrative, establishing agency, accomplishment. Okay, you can do it. Building attentional resource, being able to mindfulness and have attention to solve problems rather than just survive with them. So you go beyond coping to actually solving the problems. And you can do that. We know now through neuroplasticity, you can rewire the traumatized brain. Neuroplasticity is the brain's ability to reorganize and create new connections, which I'm happy to say that we know that that does not stop in old age. It might slow down, but you can still do that, and especially blueberries and cocoa, and different certain things can really help with that. You got to talk to your doctor about that. But targeting the triple network, trauma alters the salience and central executive networks. Interventions from the bottom up, okay, mindfulness, okay, from the top down, CBT, from both sides at once, art therapy, and okay, leverage neuroplasticity to repair specific connectivity deficits. The body keeps score. That's why dance therapy, authentic movement, embodied therapies are so helpful. Somatic experiencing, all that. Polyvagal response. The goal is a functional restoration of the executive control that trauma disrupted. So I'm no longer playing dead. I'm living fully my optimal life. A history of successful co-regulation tunes the nervous system. And that starts with babyhood. But if we don't get that, we can get that in love relations later on. We can get that in psychotherapy. We can get that with colleagues and other friends that we have. We can get that from sports teams that we volunteer to be on or coach or whatever. And we can get it by being a therapist too. Not that we're other people are meeting our needs, but this is a post-traumatic growth field. Beyond resilience, PTG, post-traumatic growth. Resilience versus growth. We want to have a transcendent function and rise above in a dialectical way those opposites. Resilience is bouncing back to baseline. Post-traumatic growth is bouncing forward like a ball. The definition: I am more vulnerable than I thought, but I am much stronger than I ever imagined. The outcomes of post-traumatic growth for a therapist: increased empathy, empathic attunement, because you're able to feel, you've been through it, you have a more idea of what it might feel in the body, what kind of images it might have, what kind of thoughts you might have, or irrational thoughts that you've had to overcome, what kind of narratives you've had to reauthor in your life, what kind of solutions you've had come forward out of your miracle of your engagement with the world. Renewed appreciation for life, exactly. Viewing trauma with equanimity. Equanimity, when we talk about mindfulness, is a whole process of being mindful and not going up and not getting down too much. A sociological approach to healing. Healing does not happen in a vacuum. Positive psychology must integrate all these systems, not just family systems. That's what we might focus on if we're a family therapist, but foster true learned optimism for our whole culture, which right now our culture is impacting that microsystem, policy, historical trauma, destigmatization, or stigmatization, all that we're working on. We want destigmatization. That's the macro system. The exosystem, the community, our trauma informed schools and workplaces, which we'll talk about in this class too. Puts up some also videos online about that, about trauma informed systems. And SAMHSA, Substance Abuse and Mental Health Association of the United States, has a whole thing about agencies need to be trauma informed, whether it's a school from the principal to the secretary, whether it's a huge governmental agency from the president on down, they should be trauma informed. Okay, Mesocyc, the Therapeutic Alliance, moving from compartmentalization to connection. We want to have unified teams to work with people that really have a lot of trauma, and we want to have early response and right in the hospital. And for instance, the people that do the nurses that do the examination when there's a child who's been sexually abused, and they film it, and they're just so sensitive, but so gather also have a legal mind to gather evidence too, so because we want to stop this stuff from happening. Microsystem, the survivor, the thriver. Okay. Okay, identify beyond victimhood, values and altruism of helping other people. Clinical considerations and ethics in trauma. The fragility of memory. Memory is reconstructive, not a recording. Okay, all the research about memory, which we can go into later, but Elizabeth Loftus and the McMartin preschool trial and all that about the memory can be implanted and things like that. Aggressive retrieval techniques can create iatrogenic therapists cause false memories. So one thing you need to know about the use of hypnosis, which a lot of people don't use it now, but a man named Alan Sheffield, who's a professor of law at Santa Clara, wrote a book called Trance on Trial. And in that, the state of California, because of that book and because of other things that happened, created a law that if your memory is hypnotically refreshed, let's say you're 35 years old and you have hypnosis and you get this memory of this past trauma, you can no longer testify because of this law in court against the perpetrator, because you can. There's not a statute of limitations, but you can't testify in court. So what he says is some therapist is not going to know that and not inform their client with informed consent. Like, listen, if we do this hypnotic, if you remit a procedure, if we proceed with this treatment of hypnosis to recover this memory, if we get anything, you will not be able to, in a lawsuit, and should sign something like that. Um, because they found out that memory can be refreshed by hypnosis. And people in the Chowchilla kidnapping 30, 40 years ago, where they kidnapped a whole busload of kids. The FBI used hypnosis and was able to get all the license plate number and things that people didn't even know they remembered by using hypnosis. So you can do that, but you can also confabulate. So what the therapist is supposed to do, if they want, is they write down everything and they tape record everything the person knows without hypnosis. Then you videotape the whole hypnotic thing, and then eventually that videotape can be turned into evidence, can be submitted as evidence, not as testimony, but as a videotape. And that the reason is so they can see and make sure that the therapist did not implant these memories into people. Okay. Traumatic brain injury in relationships. Traumatic brain injury often leads to role shifts and emotional dysregulation. Now, why traumatic brain injury? Because people with traumatic brain injury, like coming back from wars or whatever, it used to be in Vietnam, we didn't deal with traumatic brain injury. And that's because in Vietnam where people died. Now we can drop a fly over a place in the desert or in the wherever and drop a building that will just make itself into an operating room. In 30 minutes they can be operating. So now people come back with traumatic brain injury from traumatic situation. Our warriors come back with traumatic brain injuries because they live. So that's good. Okay. Also, when there is domestic violence, intimate partner violence, I try to always get myself to say intimate partner violence, but I miss sometimes. Is that, but when there's intimate partner violence, a lot of times people get hit and there's traumatic brain injury. So those kind of things happen together. There is increased risk of IPV following head trauma, requiring integrated cognitive and relational support. So let's get the end here is integrated healer. That's what we want to be as psychologists and marriage family therapists and other licensed clinical social workers, pastoral counselors, all of us helpers, medical doctors. We want to be integrated healers, merging the map and the compass. The map is the assessment, understanding the injury, the MMPI, the diagnosis, what's going on with their WISC, with their intelligence, their functioning just in their daily living, the triple network of their brain. And the compass is the intervention that we go in one direction and we want to go towards individuation and growth. So orienting towards growth, positive psychology, getting into the flow state, the PERMA uh, acronym to remember that. Neuroplasticity is what we're trying to create. Okay, so that's a lot of information uh, on neurology and trauma and the mapping of the brain. So I hope you enjoyed this. So let me stop sharing. Thank you very much. This was a really a joy for me to always put out this information, any information that might help somebody. I always feel if somebody gets one thing out of this or two things that are new to them, it's like moving them along in their journey. I'm actually also creating this for my practicum class because trauma and what we're dealing right now with therapists in California and throughout the world is there's just so much trauma. We have to be ready for those painful situations to come through. And so in the future, I'm going to have other videos on on therapist self-care and self-care for us all and various topics like that. Thank you very much. Okay. Bye bye.